these measurements that people are keeping the distance, as we say, if you're working together, if you are staying.
I am Chantal Mathieu, an endocrinologist in Leuven, Belgium. In these strange COVID-19 times, we as doctors and clinical teams taking care of people with diabetes need to reorganize. We cannot stop working. We need even to work harder for our patients with diabetes. Indeed, their disease has not disappeared. And on the contrary, they have even more questions and need our help to adapt insulin doses and other medications to the changing reality of working at home, changed exercise schedules, and sadly sometimes infections and fever. An elegant way to organize follow-up is to switch to video or teleconsulting. In our center, we have mainly put our diabetes educator nurses and dietitians to work to contact all people who have an outpatient contact scheduled for the next weeks. Let me share our experience with you. First, we send an SMS or text message to the patients, warning them that the face-to-face contact on a set date will not happen. The lists of patients for the following week are then made, and we allocate sets of patients with type 1 diabetes to our nurses. People with type 2 diabetes, where we expect more medical issues, are assigned directly to doctors. Let me give you the example of how we organize our tele or video consulting for our people with type 1 diabetes. We plan 30 to 40 patients per nurse per week. Our nurses contact the patients on their phone and plan a moment in the next few days for an extensive recontact, by which time the patient is asked to upload glycemic data from sensors or SMBG into the appropriate system. That way, the nurse can see these data and upload them in the outpatient file. The patient is also asked to measure their weight and blood pressure, if possible, by the time the nurse contacts them again. This first contact typically lasts between 5 and 10 minutes. At the moment of the second telephonic or video appointment, the nurse discusses glycemias and any medical issues with the patient and lists the needs of prescriptions of medication and diagnostic material. This second contact typically lasts 15 minutes. Then the nurse plans with the patient the final telephonic contact with the doctor. In the meantime, the nurse discusses her patients with the doctor, and one by one, at the scheduled times, the doctor and nurse phone the patient together to discuss any adaptation of insulin regimens or any adaptation of other medication, and to discuss any outstanding medical issues. This final contact lasts 5 to 10 minutes. So all in all, the clinical team now spends 25 to 30 minutes with the patient. These strange times and also the novel way of contacting patients open often opportunities to ask the patients, who are mostly confined to their homes, to pay extra attention, for instance, to their glycemic curves, and to try, for instance, those changes in insulin that before were not tried due to being at work, being too busy, not having any time. Special attention can be given on the phone to little details like the need to change the injection needles to avoid lipodystrophy, etc. Actually, patients seem to be much more aware of their diabetes in these times, so a good opportunity for education. Finally, the doctor also reminds the patients of follow-up appointments with their eye doctors or cardiologists and eventually plans them with the patient in the next few months. We limit lab tests to those patients with renal impairment or other medical issues where a blood sample has to happen. These are the only patients who are welcomed in our outpatient department. For all other contacts, answering, for instance, questions on carb counting or adapting pump settings, we invite the patient to a specific teleconsulting moment. Our dietitians and nurses are available via email or phone throughout our hotlines well known to the patients. This novel approach of tele or video conferencing with the patient demands a lot of the clinical teams, but we owe it to our patients who have lots of questions. We, as endocrinologists and diabetes teams, need to do our best to avoid the collateral damage that this COVID-19 epidemic can cause for people with diabetes. People read strange things on social media and are tempted to stop important medications, for instance, antihypertensive drugs. Or even worse, people very often delay seeking medical help, for instance, when having a chest pain or a wound on their foot, because they're afraid to come to hospital. I hope this overview of how we organize our tele and video consulting now of patients with diabetes can help you in your practice. And I end by wishing all of us a lot of courage and strength in these strange times. And remember, we will overcome this.
Help not just on the emergency part, but also on developing health systems and taking care of those countries who will be the most severely affected by COVID-19, those who have the poorest health systems, those who will have bigger